Do I still need to let Nathan know, or are you?
I'll let Nathan.
So we are now live.
Yeah.
Okay. Good morning, everyone, and welcome to the meeting of the Health Scrutiny Committee, which is being live broadcast. We move to our first agenda item, which is to note the appointment of myself, Councillor Mike Robertson, as Chairman, and Councillor Simon Wright as Vice Chairman of the Health Scrutiny Committee at full council on 22nd of May 2025. And then to move to agenda item 2, which is to note the membership of the Health Scrutiny Committee for the 2025-2026 municipal year, which is as noted on the agenda. That's not disconcerting. We now move on to the minutes of the last meeting held on the 18th of March, which you should have had a copy of. Can I accept these minutes a true and accurate record, please? I don't believe anybody on this committee now was attending the meeting, so I propose that we just accept it as a true and accurate record. Lovely. Apologies for absence. James, do we have any apologies?
Okay, Chairman. So we have apologies from Councillor Simon Wright for other reasons, Councillor Kevin Dale for other reasons, Councillor Alan Byte for other reasons, and we have substituted for Councillor Wright, Councillor Joseph Rich. That's it. Thank you, Chair.
Thank you, James.
Chair, could I just say my colleague Victoria is running late because of traffic, but she'll be here as soon as she can.
Thank you, Alex. Yeah, noted. Declarations of interest. Do any members present have any disclosable pecuniary interest to declare? No. Do any members present have any private interest, pecuniary or non-pecuniary, to declare? No. Lovely stuff. Due to the late running of Victoria, who will be presenting with Alex with regards to the fertility policy and also the financial sustainability items, I request that we move to agenda item 6 to enable partners to arrive and obviously to facilitate the progression of the meeting, if we're all happy with that. So agenda item 6 is the introduction to Healthwatch Nottingham and Nottinghamshire. So the next item for consideration is for information rather than scrutiny. It's an introduction to one of our public scrutiny partners that helps amplify patient voices in Nottingham and Nottinghamshire. Over the weekend, it was announced that Healthwatch has been selected for decommissioning nationally. This is very saddening, as we have enjoyed a strong partnership with the Healthwatch that has yielded important insights into key issues that residents experience. For example, the most recent Healthwatch report regarding patient experience of maternity services added depth and scrutiny to debate. As we're facing a period of significant change in the health and care sector, it is not yet certain which part of the health system will absorb the functions of Healthwatch to continue to ensure patient voices are heard and taken into account. We do know the role of this committee in carrying out health scrutiny in Nottinghamshire will be more crucial than ever as we maintain a public platform for bringing forward the concerns and perspectives of local residents. I would like to thank for joining us today, Sabrina and Sarah from Healthwatch. And Sarah, would you like to comment on the recent announcement?
Thank you, Chair. Hello, everybody. I'm Sarah Collis. I'm Chair of Healthwatch Nottingham and Nottinghamshire. I was actually one of the people that created Healthwatch in the first place in 2012, so I have a very long association with it. I've been chair now for 7 years at Healthwatch Nottingham and Nottinghamshire, and I'm incredibly proud of the independent voice that we bring to scrutiny, like yourselves. We work alongside yourselves in the county. We also work with the City Health and Care Scrutiny Panel, and we hold the system to account from a patient and user perspective. So Sabrina's going to talk you through what we do, but I just want to address the announcements that happened in the press, should I say. So we woke up on Saturday morning to the news that the government were proposing to abolish Healthwatch England, which is a national body which is part of the CQC, and the network of local health watchers, of which we're one of 152 across the country in England. Very scant detail at that point in the press, talk of wanting to streamline, ensure that people had less confusion in where they went with their concerns, and a proposal that patients would be able to use an app to tell the health system where they had concerns or where they'd had good or bad experiences. So that was as much as I knew on Saturday morning when I woke up to that on the BBC News. We've since had a briefing through Healthwatch England, who found out at 4 o'clock on Friday that they were going to be abolished, and our teams found out at 5 o'clock, those of us that were in the office, to get the email. So currently what we know is that there is a proposal that will need an Act of Parliament through the new Health and Care Bill, which is proposed to go to Parliament in October next year. Before that, obviously, there'd need to be consultation and inquiry into whether or not they've got it right in terms of this proposal. And so for us at Healthwatch, our key message is it's business as usual. We have a contract that you hold on behalf of the government to ensure a Healthwatch function happens in your area. And we've been successful in delivering that contract since our conception in 2012. We started a new contract this year in April for 3 years. And as far as we are aware, and as far as I think you would be aware, is that nothing changes until there's an Act of Parliament to change that situation. So the earliest we know that might happen is October next year. That would take anything between 6 and 12 months to actually come to Royal Assent and then action. So we believe that we have a long time in this world of uncertainty to actually understand the landscape that we're working within, as there's going to be more announcements this week, we believe, from the Minister on the 10-year plan. And obviously, colleagues here today from the ICB are also going through enormous change and shift. So the entire health and care landscape is very turbulent at the moment. So we believe that it's more important than ever that we provide that independent voice for people who are part of the system from a user perspective, the people who matter the most, actually. Patients, carers, those that are using mental health services, those that are using adult social and children's social care. And without that independent voice, we believe that the system is weakened. The real scrutiny to happen, you need committees like your own that are bringing your expertise and scrutiny from your local perspective as councillors, and we bring that really important scrutiny from the opinions, the experiences that we gather. So we are keen to work with you. We're keen to understand how we can continue to do what we do, whether we have Royal Assent or not, to do some of the functions. We are a charity, we're an independent charity, we're not a quango, even though the bonfire of the quangos Daily Mail headline suggested that we are. However, as independent charities, the network has got lots of agency really in how we continue to build on the trust we've already been given by thousands of citizens of Nottinghamshire over the last 12 years to ensure that we continue to hold the system to account and that patient voices is at the centre of what we do. So I can't say much more than that. We don't know much more than that, but we will be making statements publicly in the next couple of days. We've got to meet our team tomorrow, who found out, like I did, in the press on Saturday, and we'll be talking to them as a matter of urgency to reassure them of our commitment that we intend fully to continue the work that we've been doing, and that we are confident, actually, that the system wants and values. So we very much appreciate that we are here by invite to this committee. We really value the opportunity to work alongside you. And Sabrina is going to sort of walk you through how that actually has worked in the past, how we hope that continues in the future. And for us, we want to cement that relationship as something that you, as a predominantly new scrutiny board, will learn just the importance of that patient voice and how we can help you and support you in your very vital work scrutinising our health and care system across Nottinghamshire.
Thank you very much, Sarah. And I must say, we really appreciate you being here as well. So, Sabrina, would you like to take us through an introduction to Healthwatch?
Yes, thank you. So, yeah, as Sarah said, it's understandably very concerning, and not just for the sector, but for the people that we represent. I think that's the key thing for us. It's not really about us, it's about the public and the patients who use health and care services. But as Sarah said, locally, we remain here to listen, to amplify experiences and to push for improvements, really. That will never change as far as we're concerned at this moment in time. So next slide, please. So as Sarah has said, we were established under the Health and Social Care Act in 2012 as the independent champion for people using health and care services. Our core role is simple but powerful. We listen to what people say about their care. We highlight where things are working and where improvements are needed. We make sure that those insights reach decision makers and providers so that services can improve. Last year, we supported more than 400 people locally and have to have their say, and that's through different methods, which I'll go into. Next slide, please. So where we are based is across the county and the city. We cover all publicly funded health and social care services across Nottingham and Nottinghamshire. That includes GP practices, NHS hospitals, care homes, community services, mental health, social care, like everything, really. And we're especially focused on hearing from people and communities who are often underrepresented or face barriers in accessing care. Our role is recognised in the Health and Care Act, and we have a statutory place within the integrated care system. And we're here to help decision makers make their legal duty to involve people in shaping services. Next slide, please. So our vision really is a simple one. It's to make sure that people's experiences lead to better care. Our mission is to help bring about a future where everyone gets the care that they need, regardless of who they are or where they live. We work to the values that we hold ourselves. We're accountable, and we have integrity, compassion, and inclusion as our core values. So in terms of our role and our statutory function, we're not just a complaint service or a campaigning body. We're an evidence-based, solutions-focused organisation that gathers feedback and translates that into practical recommendations for change. We provide information and guidance. We support people to share their views, and we make formal referrals when necessary, for example, to the Care Quality Commission and up to Healthwatch England. So when there are very clear concerns that people are telling us over and over again, we'll use that intelligence to make sure it's fed up to the right people so they can make decisions about how to move forward. Next slide, please. So our reach. We're a small team. There's 11 of us all together. That's a mix between part-time and full-time workers. And we're supported by a dedicated group of volunteers as well. And that includes our board of trustees. Last year alone, we've supported over 2,400 people, whether that was helping them to access information, navigating a service, or sharing their experiences to shape future provisions. Next slide, please. So our work is rooted in people's real experiences. That's what we really care about in terms of lived experience and understanding what that feels like for people. So one of the issues that we hear about time and time again is GP access. That's the thing that we get contacted about the most at Healthwatch. It's our top issue. And I wanted to share a comment that was shared with us where someone had said it's horrible trying to get an appointment. By the time you get through, you can't get an appointment. And these are the things that we hear often over and over again. And although that's the case, we also do hear positive stories as well. And I think it's important for us as an organisation and as a community to also acknowledge where things are also going well. So I wanted to share this quote which says, "I want to thank the NHS and feel that they do great work. My GP has looked after me so well. Just because once they make a mistake, we should not take away the credit for all the great work that they do. I'm very happy with the NHS. When people say pay for their treatment, they realise how valuable the work that the NHS really is." So really, we're wanting to make care better. Next slide, please. How are we doing that? Or how are we able to do that? Our work really does make a difference. Last year, we helped raise the alarm on the dental access crisis, both locally and nationally. We supported smoother handovers between GP providers during transition periods. And we highlighted community views on pharmacy access and the complaints process, issues that matter to thousands of people across our area. One of the things that we really are passionate about is how we connect with communities and how we connect with our community leaders and people who are really working on the ground at grassroots level. So we put a lot of effort into making sure those partnerships and relationships remain strong. Next slide, please. Next slide. Keep going. Okay, so how we work in partnership. We don't work in isolation. We make sure that we don't work in isolation because we're such a small team. We have a big area to cover. Across Nottinghamshire and City, there are over 1.2 million people. So working alone is not possible. We have to work in partnership with others. And we do that both nationally and locally as well. We work with trusts, the ICB, community groups, local authorities, yourselves, as Sarah has mentioned earlier, to ensure that public insight is embedded in how services are designed and delivered. Next slide. So, as Sarah said, we've been in existence since 2012. That says 10 years, but it's now 11, or maybe 11, something like that. Yeah, so we've been around for a long time, and I think it's a testament to the fact that we've managed to build lots of really positive and helpful relationships. We're well respected in our sector as a patient voice, and that we want to raise patient voices as much as possible. There is a little 3-minute video if you want to watch and have a look. Can you click on that? Is that possible? Good play. If not, it's fine.
Celebrate our 10th anniversary with us as we honour you, our Healthwatch heroes. Millions of you have shared your experiences, both good and bad, about accessing health and social care. Your stories have helped make important improvements to the services you need to stay well. People like George from Buckinghamshire, whose feedback improved communication for birthing partners during labour. Rebecca from Staffordshire, who helped improve orthotic services nationally, ensuring children can access support quickly. Tony from Durham, who made care home information easier to find after struggling to find one for his mum. Errol from Bristol, who encouraged men from the Afro-Caribbean community to take up life-saving prostate cancer screenings. And with the support from health and care professionals who've listened, your experience...
So, yeah, thank you, Sabrina. That was a fantastic introduction. So thank you for that. We'll now move it to discussion so that members can bring forward. Councillor Whelan, do you want to?
Yeah, thank you, Chairman. I think just general point first, I think it is very much disgraceful about how it's, and that's been sent out 4 o'clock, 5 o'clock on a Friday. If any organisation does that, they're trying to bury something. I think that's pretty standard about that. So I think first we should be put on record. Well, I personally, as a committee, very disappointed how that's communicated out. Because if you do that time, you are, like I say, trying to bury it and don't want the debate perhaps know it's a wrong thing to do. I think potentially, Chairman, as a committee, we should be writing the government, actually asking what their plans are then with Health Scrutiny, because it might come in the bill. We know it's going to be a while away to go. If it was consultation, then like most governments and legislation, it gets delayed and delayed and delayed. And we've already seen this government's already delayed a lot of our social care in terms of reforms and everything else there. So I wouldn't be better on it being anytime soon about what's going to happen. But the uncertainty that creates, especially communication to patients, behind it being scrapped, it might be, well, I don't bother communicating the instant there, so where do they go? And we also know the CQC aren't exactly in the best shape. I think that's not being disrespectful. They admit that themselves in terms of where they are there. So the extra pressure is going to put on the CQC. We need to find out from government what their plans are to either probably reform and sort out the CQC or what they're going to do in the interim, because there is a concern, especially from a patient point of view, that things can start slipping through the cracks, as you've already pointed out the work they do. Also, please make my thanks to you, Sarah, as well, and to Marina as well, obviously, the work with yourselves in the past there, and I think thanks to your teams for what they're doing, and also the uncertainty. I've been there, done the got the t-shirt in terms of when you know you might be scrapped and not going around, then having to still go on and do the day job. So I know how hard that is implemented there. So our thanks to the team, that I think really important to do. But yeah, I mean, just as option, it's a big wider piece of work there. To we've got to really find that out there, because that is a concern just from self reading that.
Absolutely. Thank you. Yeah. Any other members wish to? No. So as chair, summarising that, but I amplify what Councillor Wheeler says. And what we'll do is we'll look into, what we can do to provide our representations to government. I've been aware of Healthwatch, obviously, since taking this position as chair of the Scrutiny Committee, and I'm learning, all the time. But I've done a good bit of research into what Healthwatch do, and I'm very impressed that you provide that voice. And I think really it's understanding what we can do to provide our representations further up the political ladder, but also understand what we can do to support and amplify Healthwatch in whatever model it takes following the fallout post legislation. And I will say we'll definitely commit to doing that.
Could I just give a plug? And obviously, as members maybe new to us, we work in a very collaborative way around the county, and we've actually got one of our showcase events coming up in Bassetlaw. This is where we bring the voluntary and community sector, who are very much at the heart of community support, together to showcase what they do, but also to find out what matters to most of people in that community. So it's a great way of learning more about what we do, and also seeing more of what's available in your area. So we make sure that we'll send you details of that. So if you can come along to one of those showcases, we'd really welcome you there. And also, if you've got any concerns that you're picking up in your constituent surgeries, things that you're hearing that you think would be helpful for us to know, because you are as part of this network of voices that we wish to gather, then we're here for you in order that you can sort of work with us. We've often taken in issues up because the local councillor has alerted us to an issue. We've had issues that might be around in Newark, where we've had issues around the hospital there that we've supported, and we've worked very closely with the ICB to ensure that patient voice has been part of those conversations. I think as well, the county's got very specific challenges for some of your communities because of rurality and access. So again, when we talk about those that are seldom not heard in the system, here in the county, the demographic and the challenges that local people have in accessing services are quite unique. And it's that we mean by that diversity as well, that we're here to listen to those communities that maybe feel that they're too far away from services or they're concerned. So, for instance, we've very much been involved in the debate and within your scrutiny of the ambulance service, for instance, and the issues that has in terms of times from, if you're in the north of the county, to Kingsmill, for instance, and the additional anxiety that can create. As Sabrina mentioned at the beginning, we cover everything from birth to death across the entire population of Nottinghamshire. And as such, we can't do it alone. We have to rely on the eyes and ears of everybody. So we absolutely welcome your input, and please feel free to contact us at any time. If you want any further information, or you want us to come along to things to talk to anything that you might be involved in, we need to spread that word and ensure everybody knows that we're here to listen.
Yes, and also we've just published our annual report as well, so I'll make sure that gets shared with you. That'll give you a really good sense of reports, because we publish reports every year where we do a deep dive into particular issues. Our most recent report about pharmacies. So we'll make sure that you have that, and you'll see all the work that we've done, give you a really good sense of how we've been operating over the last year.
Well, just before I bring the recommendation forward, I'd just like to say that I am a Bassett Law councillor from the rural north, the last bastion of Nottinghamshire. So when your event is on, please extend the invite and I'll be happy to attend. We do have 2 councillors as well who aren't in attendance today, but are both Bassett Law councillors, and I'll ensure as much as I can do that they do attend as well, because it'd be good to give that support.
Thank you.
If there's no further discussion, I'd like to proceed to recommendation, and that recommendation is that the presentation be noted by the committee. Could I, as the proposer, have a seconder to that? Councillor Cox seconds, and all in favour? Unanimous. Lovely. Thank you very much, and thank you to Sabrina and Sarah as well. Lovely. Right, let me just find my position again. So now that we have Victoria stuck in traffic,
Nightmare.
I can imagine.
Nightmare.
I arrived at about 7:15 this morning to avoid it, so I can appreciate.
Yeah, I don't know what it was. They just closed off the road into Arnold, so to do a massive divert. Anyway, so apologies to everybody for that.
Rural north of the county for
I know. And I'd already set off an hour and a half because I live at Worksop. So I'd already realised I needed to, I normally set off an hour and a half. So I thought I got plenty of time. So my sincere apologies for being late.
Well, no problem. Okay, so we'll move on to item 4, which is a report into the East Midlands Fertility Policy Review. So the next item for consideration is a report from the ICB, which outlines the results of the recent listening activity in respect of a revised and modernised policy across the East Midlands. I'd like to welcome the representatives of the ICB, Alex Ball, the Director of Communications and Engagement, and Victoria McGregor-Riley, the Commissioning Delivery Director, which I hope I got those titles correct.
No.
Oh.
we can update that.
Yeah, we'll all update that.
Okay, lovely. So Alex and Victoria, would you like to introduce the report?
Yeah, I'll just say one sentence and then
Okay.
Victoria will kick us off. So conscious we came to this committee, but not this committee earlier in the calendar year. So this isn't the first time. So, you know, corporately, this committee has heard about this item, but very aware we've got an entirely new membership. So Victoria's going to do a little bit of a history lesson in the nicest possible way to kind of talk about where we've got to sort of up until now. And then I'll pick up the thread of the what we've learned from talking to our population over the last few months.
Yeah. Okay, so potted history then. When Bassett Law came in to form the Integrated Care Board with the rest of the Nottinghamshire patch, in effect creating a brand new organisation, legally we were required to review any differences in the policies that we offered people to access healthcare across those 2 former systems. So statutorily, we are required to have a single access policy, or, you know, it doesn't matter whether you live in the northern reaches of Bassett Law or whether you live in sunny Rushcliffe, you should be able to access the same level of services under the same policies. So we have a statutory obligation to do that. When we first came together, we did a really in-depth piece of work where we looked at all those policy differences, and for the vast majority of them, we were able to align them really quite easily and simply. They weren't massively divergent at all. So that large piece of work happened quite early on. But one of the areas that we knew that there was a divergence, and there was a material divergence in one aspect, was around fertility. And what we did do was engage. Do you want to just move us on? Is it okay? We did engage with our wider East Midland ICB colleagues across Lincolnshire, Northants, Derby and Derbyshire, for example. And we said what we're trying to do is make sure that we have, as much as possible, a consistency of approach around fertility, because what we wanted to avoid was that postcode lottery approach again. We thought the bigger the geography, the more easy it was to align and be fair and consistent to our populations. So we engaged in a piece of work with them to say, can we collectively review our fertility policies and see whether there can be that alignment across all of them. So we were bringing the Bassett law into the Nottinghamshire as well as broader piece as well. So obviously, when we're talking about fertility, that's the more appropriate terminology. If you can just go up one, sorry. Yeah, obviously we're going to, in terms of fertility itself, it is about the ability to conceive a child, and obviously there are many different ways that we can support people to do that. It's not everybody just goes to IVF as a real go-to opportunity, but there's lots of things that we can do to support people. And what we do is we've reviewed all those aspects of opportunities to support people. So it's not just about IVF, and also looking at the access. So for example, there is NICE guidance, and hopefully everybody's familiar with NICE. There's NICE guidance about people who should access support. So for example, there's a range of a BMI, people 29 to 31, and there's a guidance around age profile that people should be to access it as well. So we were quite clear that we wanted to be as consistent as possible, both with national guidelines and standards as well as other local areas offering them. If you just want to move on, please, to the next one. So what we did do was, first of all, we did a paper exercise where we looked at what the similarities and what the differences were, so identify them. And then we constructed a series of questions to invite the views of our local population around those differences and hear from them very clearly about what their thoughts were in terms of how the policy should change and or not change. Alex will go into that in a little bit more detail later. And as a result of that, what we've listed here are some of those early thinking that came back from that listening exercise and from that kind of tabular looking of where the differences and similarities already were. So what we identified was, for example, in here, single women and transgender men, we felt should be offered better access, up to 3 cycles of unstimulated direct insemination, that's right, where there's a normal sperm count. There's a lot of detail in here. I'm probably not going to go into that micro level, you can read it. But we also wanted to extend it to same-sex couples. We wanted to make sure that we were opening up in a really fair and open way. Other than as mentioned, guidance around BMI, we've also included in there to correspond to NICE guidance. We think that we should continue guidance around people not being smokers, because we know that that has a very deleterious effect on the overall success of the support that we can offer. We've also considered the option around people having existing living children, so that's part of our policy as well. No provision for couples who have already undertaken sterilisation, because again, we feel that offers more opportunity for those who do want to have support, and going down to the 1 cycle across the whole patch, which is what the vast majority of people currently have. And at the moment, Bassett law has more than that. Offering the 3 cycles of unstimulated intrauterine insemination and the donor sperm insemination for those couples where vaginal intercourse is not possible. Again, we were very keen to hear from couples who felt that that was an option that hadn't been probably appropriately considered for various reasons, and includes access to the storage of gametes if a patient is due to commence medical or surgical treatment. So if, for example, somebody's got cancer and they need to have treatment that's going to cause damage, then they can have those stored. And again, and there are quite good guidance around the duration and how we do that as well. So those were just some of the things that we've identified from that exercise across, but also from what people have told us. If you could just go on to the next one, please. Alex, do you want to go to the listening exercise?
Yeah, so thanks, Victoria. So that's kind of the end of the history lesson, as it were. We took the existing policies across that whole East Midlands area and tried to get to a single kind of set of proposals, because as we've described, we think it's really important that we have consistency across that patch. And many of those proposals are about moving these policies to kind of be part of, what modern society is like nowadays. Many of them were written 10 or 15 years ago previously. So this is about moving with the times a little bit and making sure that we are offering a really equitable set of access to all of our population for the future. So that's what we sort of put out there to the population. As you can see, just kind of in the run up to Christmas last year, that feels like a very long time ago with the current weather we're having, and into January, we worked with the other 4 integrated care boards across the East Midlands to test those policies. So we did that in a number of ways. We did that through briefings with elected members like this, as we did at the committee earlier this calendar year. We went out to community groups, visited citizens in their own space, on their own terms, to hear from them. We ran a number of public events to hear directly from people. We ran a survey that was available online, on paper and over the phone. We dropped materials off in, again, social spaces where people live their ordinary lives so that we could try and reach them there. And we ran quite an extensive campaign on social media as well. And therefore, working across those 5 areas within the East Midlands, we heard from over 2,000 people, which is, for a relatively kind of sort of discrete area of healthcare, was a really fantastic result. We were really, really pleased about the volume of responses that we heard from people, and also, as you can see set out in the paper, the kind of diversity in terms of kind of geography and types of individuals that we were hearing from. Of those, about a fifth, just over, came from Nottingham and Nottinghamshire. It's probably more than that because not everyone put down where their location was. But we, between us and Derby and Derbyshire colleagues, received the kind of bulk of the responses, which is right because there's probably more potential changes for those areas compared to the other areas. And therefore, what we can share with you now, and you've got in your detailed reports, if we go on to the next slide, some of the feedback that we heard from that. So we've tried to chunk these up into kind of sort of thematic terms. All of the detail is in the report, broken down in quite a lot of kind of different areas. So firstly, we asked people what they thought about that idea of standardising access across the region, and in particular looking at that IVF treatment, where there are a few areas within our patch that offer more than one cycle of IVF. The vast majority in our patch offer one, as do the majority of other areas across the country. And we got a plurality of people in favour of that. It was quite finely balanced, if I'm honest. I think something like 45, 46% against, but there was a plurality of people in agreement with that. But there was an awful lot of feedback within that saying broadly, this should be nationally set. There shouldn't be variation across the country. Why can't we have one single policy? Now, that's out with our control as a local commissioner, but I think we could all understand that as a kind of position that our population might hold. Moving on to thinking more broadly about that kind of move to a more equitable policy, moving more to kind of what the modern understanding of a family is. Very strong support for these proposals, 70+%, touching on 80%, high 60% of people saying that they agree that that should be part of our policy. Whereas the historic policies are broadly silent on these. And so we do think it's important that we kind of move with the times and do offer that more kind of responsive and equitable policy that reflects modern society. There's quite a technical thing around what's the best kind of clinical pathway of offering, I'm not going to try and pronounce them, IUI and DI, which are 2 types of kind of lower kind of, impact on the woman sort of treatments before you kind of move to what is a very invasive set of procedures within IVF. And broadly, there was quite an agreement that we should be offering those kind of first steps of the clinical kind of offer, although it is recognised they are less likely to be successful. It's a trade-off, isn't it? You could go through quite a kind of invasive, quite emotionally and physically draining process that has a bit of a higher success rate, but why don't you try these ones first that might have a slightly lower chance, but are probably less kind of intensive on you and kind of your body. And we've got a good kind of level of support for that as a set of proposals. So if we move on again, please. Again, quite a technical thing, but if you are going through fertility treatment and you are potentially also undergoing treatment for something like cancer, which could affect your fertility, there is an option to store your gametes, so your kind of reproductive cells for future use. Very strong support for that overall. A bit of debate about the length of time that those gametes should be stored for, and there's slightly different kind of clinical guidance in different areas on this, I think. And there was a recognition that if you're going through certain types of treatment, you may need a longer gamete storage period than other people. So there may be something we'd want to do about tailoring that a bit. Victoria mentioned a policy around current children. So what we mean by that is if a couple have come together and are having fertility problems, but one or both of them have children from a previous relationship, then our policy proposal is that you would not be eligible for fertility treatment under this new policy if you have a living child from a previous relationship. That was quite controversial, to say the least, and nearly 2/3 of people responding said they did not support that as a policy position. So we've had some very clear feedback there that perhaps we haven't quite got that right, and that's something that needs to be looked at again. Really strong support, which is, I think, is good, and I hope everyone can get behind that. You wouldn't be eligible for any of these treatments if you are currently smoking or vaping. We know that has a massive impact on fertility rates. You've kind of got to do everything you can yourself to get your fertility to the best possible place before you can kind of access additional treatments. And yeah, 90% of people were very much on board with that. Next slide, please. So that's a headline summary of what you can see in the report of the feedback that we've had on that proposal, that proposed set of policies. So if I just kind of really quickly recap, we've got at the moment a whole range of different policies across the East Midlands. Those are all kind of currently still live and what you kind of have to sort of match yourself to if you want to access these policies. We have proposed a single unified policy for the East Midlands. We have tested that with our population, and I've just taken you through what the feedback from that testing was. What we are doing now, not literally now, but in other rooms with other clinicians and experts, is working that all through, looking at that feedback, thinking, have we kind of got that right? Have we learned something that we didn't realise there that has a bit of an impact that we weren't expecting? So we're working that through, and we don't know what the outcome of that is yet, because that's being done by the real experts, the doctors and nurses who work in this space, and the commissioning managers who know how this sort of thing works. But they're working that through, and therefore there may or may not be some tweaks to those policies, that policy that we've proposed earlier in the year and that we've tested with the population. So then once we know what that looks like, we will be looking to come back to you again to say, here's where we are now, here's what we've proposed, here's the kind of final proposal that we're looking to take forward. And there'll be a number of kind of approval steps and meetings and reports and all that kind of thing that you'd expect. But that's kind of ahead of us for now. So that's everything we wanted to say, really. So hopefully, without it being too much of a history lesson, we've been able to sort of take you from where we were to where we are now and a bit of what the future might look like as well. Thank you, Chair.
So thank you to Victoria and Alex for the introduction to this topic. I'll now open up the discussion. Councillor Thatcher.
I've got a couple of issues that I want to raise from the report, if that's all right. I was wondering how obvious it was made to survey respondents that you were rounding down from 3 rounds of IVF and Bassett law to 1 for everybody. Because I believe the NICE recommendations are for 3 rounds across the board. And I know not everyone across the country gets that at all, and there is very much a postcode lottery. But I wonder if people would have been so in favour of standardisation if they realised in Basel that they were losing 2 rounds, or whether people who were living in parts of Nottinghamshire thought that they might be able to get 4 rounds funded, and now they're not going to get it.
Yeah. Do you want? I'm happy to start, and then Alex knows a lot more detail. It was really clear, and I think we have really tried. I was very keen to make sure that the Basel voice was heard as part of this, and we did reach out to local groups as well to try and get as many one-to-ones, really highly qualitative kind of opportunities to hear people's voices as well. So I am really clear that we've been really open and transparent about that being one of the things that we considered. So I do feel quite assured about that. Alex, do you want to add anything on?
Yeah, I think that's right. We have to run a really kind of fair and kind of almost neutral kind of survey questions. But I think we have done the right thing in terms of pointing out really clearly what the proposal is, what the status is currently, and what the proposal would be. I think based on the feedback that we received, particularly from elected members in the Bassetlaw area, I think it was clear, and we've definitely captured that that is not to everyone's preference. But as always with commissioning decisions, you have to balance what's the best clinical advice, what's the best kind of operational way of delivering a service, what's the best financial position, and what the citizen wants. And it's a really complex kind of balancing act, isn't it? So we, I think, are kind of aiming in the right direction on this, but we're never going to satisfy everyone. I think that's undoubtedly true, but we have to live in the financial constraints that we live in, but also in the kind of clinical kind of best practice. It's worth noting that the success rate of second and subsequent rounds of IVF are very, very low. So if you've been, this is really difficult, isn't it? Because this is really personal and individual for people, and I don't want to seem dispassionate about it, but if you've been unsuccessful in round 1 of IVF, your chance of it then being successful in rounds 2 and 3 is diminishingly small. So that's really hard. If that's, you know, if you really want that and be able to kind of achieve having a family, it's really, really difficult. But we have to kind of, balance that reality of it's a really invasive, really kind of exhausting in every sense of the word process. And if it's not very likely to be successful, sometimes you have to make that call, don't you?
Just wondering if you could share any figures with us, right? Any figures about how many IVF rounds that you do fund, like on an annual basis, to see what costs involved are and how many people come involved.
I'm sure we can. There was some detail in the report itself.
I've got it here.
Yeah, so we could,
So this is for the financial year 23-24, so it's slightly out of date, but there's quite a reporting lag on it. Across Nottingham and Nottinghamshire, there were 61 cycles of IVF across the whole patch. So that's for our 1.2 million population. 11 of those were in Bassetlaw. Over the past 2 years in Bassetlaw, there were 14 cycles of IVF. So that would imply 3 in the prior year, 11 in this most recent year. So it does kind of swing around a little bit. The overwhelming majority of those, so 10 of those 14 were first cycles. So you end up with, 4 of more than kind of first cycles. So again, for that individual and for that family, it's incredibly important. And I'm not for a minute downplaying that, but the scale of what we're talking about here is in the scheme of our 1.2 million population and all of the health and care services that we offer, it is a small part of our offer.
One more issue. It was on the current children bit of the policy, which is definitely kind of the controversial bit, but I feel like there's one group of people within this who aren't given the same chance of being parents as the welcome single women and single sex relationships now can be included in it, and that's a really positive step. But if you don't have any children of your own and you're in a relationship with somebody who does have children from a previous relationship, you're being denied. You're really the only group that's being denied any chance of being a parent with an NHS-funded IVF, and I feel like that's really fundamentally unfair. You'd be better off, like, as a woman, splitting up from your partner and going and doing an IVF single. And that can't be right. Is there any way that can be addressed?
Well, as we said, we heard that really loud. You aren't the first person throughout the whole listening exercise that brought that up. And again, that is one of the things that will have to be considered as part of any future decision-making process around the policy. So I think what we are doing at the moment is making sure that the voices have been heard, captured, absolutely. They will form this next process that Alex outlined about coming together with these visions about how do we want to take it forward as a group and or not individually. We do need to make decisions around the policy. and then it will go through our internal decision-making process, of which you and further, you'll be involved as part of that. So until we've got to the point that we actually do say this is definitively what we are proposing to do, I think all voices, including yours here and now, will be taken into consideration as part of that process. So you're not raising anything that is unique or we've definitely heard that. Thank you.
Over to Councillor Wheeler.
Yeah, thank you, Chairman. And again, thanks for the presentation, going through that. And I know there's a lot of work to be done, but my main point really is following from, especially around the Bassett law cycles and then trying to go down to the one cycle across the whole Nottingham. Now, I understand with taking over the Bassett law CCG, there was the disparity in trying to go to a set standard, but my concern really on the wider issue where we've got declining birth rate, and we know in the next 30, 40 years, not going to have people to be able to support the adult social care sector, where the age demographic is going to be. And so you've got a massively increased immigration to ensure you've got enough people who can work and support that sector, or we've got to find a way to increase the birth rate in society. And there's already enough barriers we're going to get onto, and our colleagues will. But when you've got families who generally want to try and have a family, and again, I know there's a lot of health issues there, and they might not potentially be able to have children going through the cycles. I just think it's the wrong approach to effectively take away the opportunity for some families. And even the numbers just mentioned there, I mean, we're not talking like the money saved doesn't seem there's going to be a lot of money in relation actually. And I know you're in a difficult position at the ICB with the announcements. We're going to get on to the next slide, so obviously around funding. But when you've got families who generally want to try to have children, and the fact that they're going to be denied that because of the going down to one cycle there, and so that general society we're going to be, I think something we really got to look at, and that's recognition going back up to as part of this review. I think as a committee we need to be putting an view on that to say this needs to be looked at again. Nice guidance there for reasons already said, and I appreciate not every ICB follows those, but they are there. The guidance are there for a reason, and I think actually the fact that we support that just because of the position we're in. So as Chairman, I'm not in favour of downgrading that there, and I know there's a lot. Frankly, you mentioned the work that previous pastoral councillors did. I know Councillor Bailey raises a lot of times. I do think we need to look at that again.
Chair.
Absolutely.
So I think that's really helpful, Councillor Wheeler, and we heard that last time, and I'm grateful to hear it again because I think it is an important part of the consideration. I think though we need to just try and look at perhaps the slightly kind of wider angle picture around, because I absolutely agree we have a population time bomb going on, don't we, in terms of kind of demographics. But the overwhelming reason why why families aren't having children or having more children isn't because of fertility, it's because they can't afford it in terms of kind of, the cost of raising a child. So that's the kind of number one reason. And the second reason is because people are concerned about the kind of state of the world, climate change, kind of things that are going on. So these are massive societal issues around the state of our economy and the state of our world. It's not really within the purview of what Victoria and I do, nor of this committee. But if we really want to improve, our population kind of balance, it's about getting our economy growing and doing something about climate change rather than necessarily, 61 cycles of IVF in the most recent year. That's kind of probably not going to be the thing that might make the difference to people's willingness or ability or propensity to have children. That makes sense.
That's a follow-up question.
Yeah, I'm not just going to Alex said there. So the thing is, we've got to look at what we can control. Like I say, we can't control the thing that you just mentioned, Alex, as much as we could. With that, so it's actually looking what's in our ability to do. So actually, as again, going back to the point, if people are generally want to have the opportunity to have families, what we can do to have support there, because I really agree with Alex there. Like I said, as your words are thinking time bombs there, but when people want to have the opportunity, and you talk about cost as well. When we got is then if you have got the money, you can go private, but we're going to discourage, especially in some of our poorer areas of Nottinghamshire where people are not able to have that same opportunity, which is kind of widening that divide. So I completely get the position you're in, Alex, and the ICB again. As you know, from my previous roles, I completely understand that and sympathise with you being put in as we go on to the next item. But it's just looking at where those priorities are, how we can look to help those families who generally, like I say, want to have children, because the wider issues already mentioned.
Look, it's really helpful, and that's part of the kind of consideration and the feedback that we're getting and have got. That's what feeds into our kind of thinking going forward. So no, appreciate it.
Yeah, at the risk of being somewhat controversial, I have a question on what makes a single female And the statement is it is considered a fertility issue. How did you come to that conclusion about the single female having a fertility issue?
I'd have to leave that to a clinician to make that decision. I think it's a clinical decision based on the individual themselves. We wouldn't be privy to making that clinical judgment. That's not part of the policy.
But it seems like it's an all-encompassing statement that single females who, looking at this, it's a lifestyle choice to be single, and therefore have got this idea that, you know, they should be getting fertility treatment because they don't want to be in a relationship. Now, I'm just trying to understand how that come about. How's that come about that, you know, a single female is considered to have a fertility issue? Because on the statement, on the thing that says single female and trans men are considered to have fertility issues.
Yeah. So if, for example, I can only guesstimate, if you've got like endometriosis, or you've got polycystic ovaries, or you've got something that makes you becoming pregnant really problematic and difficult, yeah, I would imagine that falls into that category. So I think there's a broad spectrum of things that may fall into that category. So it would depend on the clinical decision at any one time with that individual, but it'll be those kinds of things.
So they're just, I'll just give you one follow-up question. Okay. So bring other members.
Okay. Yeah. Sorry.
No, just one more. One more. Okay. Yeah. Just so I can bring other members in. That's all.
I thought it got to me off.
No.
Sorry.
Not yet.
Yeah. There's another statement in the document as well about how we know pregnancy creates strain on the body and on the mental well-being across the board. Now, as a trans man, I'm struggling to understand they either want to be a man or they want to be a woman, and I'm trying to understand why we're looking at trans men as again having a fertility issue, because the statement is that they're a trans man.
Yes.
So when do they suddenly become one, or when do they want to become pregnant? You know, and again, the mental well-being is I would imagine the utmost importance. Is this going to cause more issues than create solutions to?
I don't think it will, because I think each case is unique and will be considered sensitively to that individual and their particular circumstances. So I don't envisage that creating any more or less challenges than for any other person that falls within the remit of this policy. So I think people will want it transgender for whatever personal reasons they have. I think it's very difficult for anybody else to have a kind of a statement of intention of whether that's the right thing to do or not for them. I think that needs to be between them and their clinician, and we would expect each individual case to be considered sensitively based on its own merits. So I don't envisage it being a particular problem at all, creating any more undue hardship for that particular group.
Okay, just one quick question, and it's
very quick one.
It is very quick. So the numbers we've got down as 2,047 surveyed throughout the county of 1.2 million.
So that's across the East Midlands.
Yes.
Yeah.
So with that number, would that be a fair reflection of society, do you think? That small number?
So you can see the demographics at the back of the report. It's pretty representative. It's got a good spread in terms of ethnicity. We always, in any kind of health survey, get far more responses from women than men, but actually there was quite a good chunk of men that responded to this. It's about 4 or 5% of people indicated they weren't heterosexual, which is actually slightly higher than the kind of general population average. So look, we can always do better, but I think it's pretty good. But we don't just take, well, that's the numbers, 200 people said that, it's a referendum, tick, you know. It's about a much wider kind of group of the kind of more qualitative feedback we get from here and the clinical best practice and, yeah, loads of stuff. So I think it's good. Is it perfect? No, because it's never perfect. But I think it gives us one element of the evidence alongside lots of other things.
Did you want to come in on that point now? Or?
If I may, Chair.
Yes, yeah.
So, morning everybody, I'm Viv Robbins, I'm Director of Health Scrutiny Committee.
And I suppose I just wanted to support some of the comments that Alex was making there in terms of when we're looking at doing what I would term as a qualitative analysis, which is understanding people's thoughts and views rather than numbers. It's much. Can you hear me?
Sorry,
Yeah.
Councillor Adigoki can't hear very well.
Actually, the sample size is always significantly smaller. And actually, I thought that this was, from my professional opinion, I thought this was a fairly comprehensive approach in terms of how they have tried to engage with a range of different approaches and a range of different groups to get a range of views. Would I have liked to have seen some more Nottinghamshire specific and some specific in Bassetlaw? Yes, I probably would. But actually, I thought that as a package, and having done some work in this sort of field previously in my training, actually, I thought this was a fairly comprehensive approach to enable us to get as many views as possible, and acknowledging that we're still on the process here in terms of getting to that final policy. So I just wanted to provide a little bit of professional backing up to say that I thought it was a reasonable approach for what I would expect in this situation.
Thank you. Councillor Upton, apologies, I've kept you waiting. So.
No problem. I just, excuse me. Thank you for the presentation. I'm new to this sector. I've been a councillor for 10 years or more, but I've never been involved with health in any aspect. So forgive me if some of my questions are fairly naive, but yes, with time I shall improve my knowledge. I just wanted 2 points. I wanted to endorse what you said. I think, my apologies, Helen Passio. I do endorse it. It was a point I was going to make, and I think you acknowledged that you would look at it again when you said, I think roughly 2/3 of the respondents were concerned about exclusion of people with children from a previous relationship. And that was a question I was going to say, you know, modern living, whatever your view on it is, modern parenting, I think there is what I call a blended family, and I think it's the points you made. So it's just an endorsement, and thank you for the offer to revisit that. And my second point was, so would I be correct in thinking that all the proposed fertility policy or policies you are confident will be consistent? I think that was your word, a consistency across the 5 areas of the East Midlands. That is your ambition.
That's our ambition.
All the policies around fertility.
We'd like to achieve.
That's what you want to achieve.
That's what we're trying.
Whether or not then that becomes consistent with the national picture.
Yeah.
But you're looking at East Midlands, 5 areas, all policies consistent.
Yes, that's what we've set off to try and deliver.
Well, I can
and that's the next stage of the process.
Thank you. Got any further? Okay. Councillor Barlow.
Yes, thank you for the presentation. My question is around sort of the BMI and the age and lifestyle criteria. So obviously people think that BMI is outdated, but I also think, obviously we do know there's an obesity crisis as well going on. So I don't think it needs to be completely ruled out. And also age limits. Now, as Alex alluded to, we do find now that lots of people choose to have children later in life because they can afford it. Whether or not that's the right way to go about things is a thing. So how will you actually implement this sort of BMI age limit crisis? Can a more flexible case by case approach be implemented to reflect that sort of thing, individual choices?
The policy will be the guide rails in effect for any clinician supporting people through this journey. So the age range is 42 and under now. So even that actually, from a few years ago, it was lower than that. So that actually has increased. And the BMI range is 19 to 30. What we do know clinically is that people's success rate diminishes greatly depending on age and depending on BMI. Those things have massively important impact on people's overall success. So there's a really good scientific evidence base around why those guide rails have been put into the policy. So I think it is, again, the balance of absolutely wanting to support people to achieve the outcome that they want for themselves, their families, absolutely wanting to do that, but making sure that we also make absolute best use of the public sector resource that we've got to enable people, support people as they go through that journey as well. So that's why we've put that in there. So it is on the basis of really good evidence as to why that age range and that BMI are most suitable for this particular policy.
So would they consider, I know you're saying that's safe, but if there was an individual case of somebody being over 42, would they consider that?
We do have a route where cases of exceptionality may be considered, but that is supposed to be for extreme exceptionality. But there is that route there. But I think generally it would be fair to say that people will be sticking to the policy and the guidelines there.
Sabrina.
Just one question, yes, thank you. Yeah, really interesting presentation. Thank you for sharing that. I've noted in the report that it talks about the mental health impact, where it says there was a strong demand for improved mental health support throughout the fertility care and support from successful treatments. But that isn't reflected in the recommendations. Is there a reason for that disconnect, or what's the thought around that?
I think there's a view that we do offer really good support already. There is an awful lot of work supporting people through pregnancy-related mental health conditions and post-pregnancy support if they go through the process as well. So I think it's because we feel that there is a good resource there, but we could possibly bring that out a little bit more in terms of saying what else and what that is. Yeah. I think that's fair thing to highlight. Yeah. And do that.
Okay, thank you.
Do any other members wish to make comments? Or I jump in? Okay, so yes, thank you for the presentation and all the responses to the committee so far. Me being me, I always do a little bit of background research. So I looked at the Human Fertilisation and Embryology Authority, who conducted a study of IVF and DI uptake. That was over a 4-year period, 2019 to 2023. It was published last month. Well, yeah, pretty much give a day last month. Of IVF uptake, and from what I understand of the sampling, the majority of this was actually private sourcing of treatment rather than NHS. But of IVF uptake, there was an increase of opposite sex couples of 1%. But of single patients, and I assume single female is what it refers to, there was an increase of 83%. With DI, it didn't detail IUI, just detailed DI. The opposite sex couple uptake reduced by 40%, but the single patient uptake increased by 16%. Now, as I say, from my understanding of the data, the majority is actually private access. It's not through the NHS. But with the sort of proposed policy we've got coming forwards, there is, in my view, a great potential that we are going to move a huge amount of cost of single patients who Councillor Cox highlighted is really, yes, there's a lot of, sort of nuance to why single patients wish to come forward to conceive, but it appears somewhat to be lifestyle choice. So are we going to start to move a lifestyle choice that is in the sort of the private medical space into NHS space, and therefore increase the costs of potential IUI, DI and IVF treatment, whilst at the same time, as Councillor Faccio and Councillor Upton have highlighted, that we are restricting to those that are in a blended family, myself being one of them. And I'll just touch on some of the points you made, Alex, around moving with the times, more equitable access, modern understanding of a family. I feel like I am in a modern understanding of a family. So do you have those concerns that I do, that we are moving cost in, and as Councillor Wheeler said, not really making any savings given the data that was provided about those who were going through first cycle treatment of IVF in Bassetlaw? So
as I kind of just replaying back what I think you're saying is that there's an potentially an unintended consequence of this in terms of more single people wanting to seek support, and inadvertently we are promoting a policy that at the moment, in terms of recommendations that we're thinking about, promoting a policy that might not support and encourage people in couples. I think that's what you're saying. Is that right?
Yeah, couples that already have an existing child. Yeah,
okay. So I think that's something to think about. I think that's something as part of the next stages and making the recommendations of the policy. That's a voice, that's an opinion that needs to be brought into the mix, absolutely. I'm sure colleagues, our clinical colleagues will want to bring in whatever is the latest information and data, since we've originally done the survey and the original assessment of the policies themselves. We'll always want to be maintaining up-to-date information as part of the decision-making process as much as we're able to. So we can add that in as a concern that's been expressed by yourself. I think there is always going to be when we embarked on this, we were always clear in the early conversations. One of the starting points wasn't about money for this. It was about the consistency of policy. It was that requirement that we needed to do it. So although money is obviously a concern, and you are going to have the paper next that shows that we are absolutely focused on making sure every penny counts, it has not been the primary motivating factor behind us doing this piece of work, but it will be one of those factors that we do consider in the round with everything else. So again, if we feel that that is going to create that economic impact, that will be played into the decision-making process.
Yeah. Okay. I think you've answered most of what I've thought to ask. I think the only other thing for me, in fact, no, it has answered that question. So unless any other members have got other points to wish to raise, essentially what I'll do is I'll summarise the debate as such, or the discussion, shall we say, and really, there's been some great points that have come out from all contributors around what the cost is at the minute and the potential savings. I know you said cost isn't the primary factor, and then obviously I've expanded that to look at the potential of unintended consequences of cost as well. And I think there was some great points brought out about not limiting certain people who potentially, through no actions of their own and of lifestyle choice, wish to be part of a opposite sex relationship that has had a child previous to that. So therefore limiting some women from the opportunity of experiencing conception and then childbirth and growing, sort of bringing a child into the world and raising them. So for me, I do think there is more to think about coming off of this listening exercise. And as you say, the scrutiny and comments that we bring on this committee, please do take them back for further consideration as well. And hopefully that will then bear fruit in some form of policy that we can probably all get behind in terms of its provision for the residents of Nottinghamshire.
That's really, really helpful, and it really do appreciate the thought that you've given to this and the comments that we've received, and your opinions are very much welcomed and will be considered as part of the feedback that we give. So thank you.
Thank you very much. So I would now like to move recommendations. The first recommendation is that the feedback of members on the results of the listening activity and how the results are to be included in the revised policy be noted. As the proposer, can I have a seconder? Councillor Faccio as seconder, and all in favour? Unanimous? That's it then, only proposal. There we go. So now we will move on to item 5, which is the NHFT financial sustainability update. So the next item for consideration is a further briefing on the proposed changes resulting from the financial sustainability measures in the NHS. Again, I would like to welcome representatives from the ICB, Alex and Victoria, and I would invite you to introduce the report.
Move on to if it's okay with everybody, I'll just kind of do some intro, and then Alex will join me. A bit of a double act today, so I hope that's okay. I think we.
Sorry, are these the right slides?
No, I didn't know.
Okay, thank you. The date on it from October.
Yeah,
so I think it's worth saying again, as I introduced the kind of last item, this isn't the first time that we've brought this topic to this committee, and I can't expect it will be the last either. But that's very deliberate, because this is really material and really important that we enable you as a committee to really understand some of the really quite difficult decisions that the NHS as a whole has made over the last year and will continue to make over the coming period. So this is a relatively high level for this kind of coming year, but hopefully it will give you a chance to kind of start to kind of understand the framework that we're working in, and I think it'll hopefully signal a number of kind of forthcoming conversations. Do we have the right slides?
I check these.
Do you want me to send it over?
I think, Prem, are you sending it to Catherine now? Yeah. Apologies.
I can just start talking.
I feel much better.
I know you didn't see the Well done, Alan. As we did mention in the induction meeting with you, we do have growth of funding coming into our system, but as people will also be aware, the costs and the demand continue to increase. As a result of that, we have to make sure that every single penny is making the most impact that we can to improve the overall health and well-being of the people that we serve. We do have a legal duty, a statutory duty to achieve financial balance. That is absolute non-negotiable. And indeed, NHS England have been very, very clear of the expectation that that will be achieved within this and forthcoming financial years. So the quote that is up there is expenditure incurred by the board, that's the integrated care board, in a financial year does not exceed the sums received by it in the year. So it's very, very clear that we do have to achieve financial balance, and local authorities will know that only too well, that similar expectation. We've done some amazing work with our teams, with our colleagues and our partners to achieve significant savings in the last financial year. And we need to maintain that momentum to achieve, again, in this financial year, savings in the order of about £280 million. So it is not an insignificant amount of money that we do need to save. In order to do that, last year, we very much prioritised of those opportunities where we could gain much more efficiency in the contracts that we already did, the way that we provided care. We, for example, did a lot of work with our GP colleagues to say, instead of prescribing drug A that may have been £4, can you prescribe drug 3B that does exactly the same thing for £3? So that kind of efficiency in the way that we did things. We have gone through line by line the contracts that we hold, literally line by line, to understand how can we achieve greater efficiencies in that contract value. So how can we create a 4% efficiency but not diminish the frontline care that we give to patients. So we've done an awful lot of work on things that actually are behind the scenes, not directly impacting on patient care, frontline services, but really creating those efficiencies in the way that we do things. I think somebody mentioned procurement. What can we do around procurement, for example, in a much more efficient and cost-effective way? Those are the kind of things that we've been looking at. How can we collaborate with our partners to do things together as opposed to individually, where we've potentially got duplication and waste, and avoid some of that? So a lot of that happened in last year and continues into this year as well. So other things like ensuring compliance with policies. So, for example, if we've got an age limit in a policy, we do expect people to stick to it. If we say that there are certain conditions that evidence suggests need to be met, or thresholds that need to be met before treatment can be given, we are actually saying that absolutely we will hold you to that as a provider of health services. And we're being really rigorous in that. And those kind of things have enabled us to achieve that considerable saving that we did last year as well. So that's some of the stuff that we've already been doing and continue to do. if we go on to slide 4, please. And then what we realise and understand is that a lot of that will get you so far. There's only so far you can squeeze the lemon pips, as it were. But then you really do need to start doing true transformational change in the way that we do things to really get that sustainability of efficiency over the longer period. So in order to get that recurrent saving year on year on year, we have agreed a set of 8 programmes of work that are identified on the slide here. And we are working really collaboratively across our NHS provider landscape and with our local authority colleagues as well, to really see what can we do that's transformational on these agendas that will give us that sustainable difference. So one of them, for example, is the Local Care Together programme. That's a programme that I'm the exec sponsor for. And in this programme, we are truly thinking about how do we come together to create integrated neighbourhood teams, that our teams work much more collaboratively so that we avoid the duplication that we've got, that we improve handovers so that we support people to get to the right person much earlier in their journey, that we don't have, or we can eradicate the sense of no right door. So making every contact count, and your public health colleagues can talk to you about what the opportunity is around things like that. So in each of these programmes of work, there is an expectation of an efficiency saving and work programmes associated with achievement of those that will be progressing throughout this financial year and beyond as well. So there is a robust oversight arrangement in place across NHS providers and also including our local authority colleagues. So that's what we'll carry on with. And as and when we come through things which are indicating significant change or things we think are significant change, we'll come back to you and inform you, and we'll have a conversation about how we might want to take those things forward. So at the moment, what we're trying to do is give you the sense of there is a large scale volume of work happening to try and achieve these savings, but our focus is, as far as possible, not to impact on direct patient care wherever we can do that, and extract it from that more back office corporate type of production of care and support, and also create efficiencies in existing contracts and arrangements.
So, as Victoria said, absolutely our intention is to try and minimise the impact on frontline services, but I don't think that's going to necessarily be possible as we kind of move forward throughout the year. I think we need to be realistic about that. So we therefore want to be really kind of mindful and have a really kind of appropriate but proportionate approach of how we're going to assess the impact of any potential changes that come out of that. So we are pretty well versed in the NHS of doing what we call equality and quality impact assessments, EQIAs. That's quite a kind of broad kind of piece of work that looks at all the possible facets of the implications of a potential change. When a sort of a programme, as Victoria's described, or a kind of scheme starts to come forward and starts to be shaped up, we run what we call a screening tool to sort of kind of do a first early pass to say this could have quite considerable impacts on this population group or this particular condition. We need to really kind of dive into this and really understand it. And that goes over and above our kind of, legal duties in this. And in particular, we're very interested in, as I'm sure colleagues on the committee have worked out, but you will do soon if not, the NHS isn't one single body. We are multiple bodies, and there are sometimes decisions made in organisation A, perhaps not connected with something made in organisation B. And so we need to kind of thread all this together to check that we've not inadvertently, doubled the impact on a particular population group or kind of missed some kind of impacts. So doing that at what we call a system level is going to be a really important part of our thinking as well. So if we could just go on a couple of slides just on that one. So next one, please. And again, as we discussed at our informal induction session last week, when there are proposals that come forward that we need to talk to you about, we absolutely will. And it may be that you will want to spend more or less time on some of those, and that's a conversation we can have. We'll be guided by you about what you think is most proportionate and most important for the communities that you represent when we bring changes forward. And if you hear things, I've heard, Alex, Victoria, such and such is happening, just ask us, because it might be true, it might not be. It might be an idea that's being considered, but definitely hasn't been taken much further forward. We'd really much rather talk to you about things at quite an early stage as they start to progress, rather than kind of much later on down the track. So more to come on this, but we wanted to kind of quite early in the life of the committee, make sure you kind of understood that overall context of what we're working in terms of our financial position and the approach that we're taking the Victoria's to solve.
So yeah, thank you, Victoria and Alex, once again. I'll now open up for discussion. Councillor Wheeler.
Thank you, Sharon. Again, thank you for the presentation. Through that, I mean, so there's two concerns really. So with the fact that you're putting the savings in, again, I'm sure you acknowledge this, and we're all in an organisation, there's transformation that you could be doing anyway, is that money that could be saved in services, that's natural in any organisation, and we're no different here. But the fact we're billions of pounds being spent on the NHS in general, as we keep seeing some lovely announcements coming to the press, but we keep cutting money in ICBs, now like social care reform being pushed down, etc. All you're going to do is effectively push the bill back onto the NHS, and the extra increase in funding just gets swallowed up by taking on more responsibilities from elsewhere, or dealing with the impact of cost by not doing prevention at an early stage. So as the rest of the council, my main concern is the amount of joint packages, the amount of joint work we have. So there's a lot of work we do around mental health packages with the NHS and ICB colleagues. I know from my previous roles, and we work very well together. And my concern really is, as part of the savings you've got to undertake, the impact on those services. So which of the joint funded packages, if any, are being earmarked for review, and what's the risk analysis being used on those? Because I think just for especially new members of the council there, if those joint packages are withdrawn, either as a council we have to decide to take on that cost ourselves, or those services to reduce or go. And if they do, obviously we still have such responsibilities, we still have to look at elsewhere to do it. So it can have a huge impact on the council. So hence I'm asking the question.
There's an awful lot of work happening around continuing healthcare generally, and complex case management as a result of that. And I think we're doing that really well in partnership with our local authority colleagues, both from a county level and for a city council perspective as well. And indeed, local authority colleagues have been extremely supportive of our joint approach around this, and that is very much welcomed and gratefully received, and hopefully will continue, absolutely. And indeed, what we also like to work with local authority colleagues in the future around, think about how as a strategic commissioner we do things together and commission things together much more collaboratively. In terms of continuing healthcare, yes, we've reviewed our policies, and we continue to review our Section 117 policy around mental health support. And again, we will be doing that in partnership with local authority colleagues. We aren't doing this with any intention to cost shunt at all. We are very keen, however, to make sure that we continue to deliver on our statutory responsibilities as an NHS, and to make sure that we optimise the care and support that we give people appropriately. And what we have found through our interrogation and using, in some instances, other people to support us in this, we found the opportunity to actually give people the much more appropriate packages of care and support that they need, where people haven't been reviewed as systematically and as frequently as perhaps we could have done in the past. And so that's much more rigorous now, making sure that people are on the appropriate packages for them. So absolutely hear the concern, and I think that's quite right to explore that. But I'm hoping that the partnership approach that we've got will ensure that we are both, as organisations, doing what we need to do for people within the budgets that we've got available.
No, and it's good to hear that again, Victoria. As you know, I know the great partnership work we had there. I suppose my concern is really making sure if any of those joint packages come under consideration for review or getting rid of that, again, I know there's the two Health Scrutiny Committees we've got here, both internally and externally, but that those decisions would come back to this committee for us to be able to have the debate and discussion with yourself, because again, the wider impact that would have on not just the council here, but the wider Nottinghamshire impact, if we were to not have those in place. So I just know, we think the early intervention mental health teams, the crisis support teams, they do a lot of prevention work. And although as a council, we have very little statutory responsibility for prevention services, we see the councils out there who have gone to financial difficulties, one just a mile away or so. And when they cut those prevention services, they have a huge impact on not only residents, but across the council. So I think it's just about answering that huge impact there would be on our residents there, and having that brought back for that open debate in a public forum would be
renewable.
Councillor Robertson.
Thank you, Chairman. Yes, thank you for the briefing note. And unless I'm mistaken, it talks about extra money in and some money going out, whatever. I can't find what the overall budget is myself. Being new to this, I apologise, but are you in a position to say the news million what the Nottingham and Nottinghamshire ICB budget is per annum? Because I have no idea.
Yeah, I think it's about 3.5 billion in total. That's across everything,
Yeah.
the whole system. But as a system, in terms of the support and the income we also receive from other commissioning organisations outside our boundaries, as a total system, it's more about 4.5 billion. So it is considerable.
It is, isn't it? Are you facing a overspend or the opposite this financial year? I've no idea whether you talk that big figure of 3.5 or 4.5 billion. What's your feel? Clearly, I get the feeling from the media that you're pushed, you're stretched, hence the cuts are coming. But I mean, are you facing an overspend?
Yes.
So that's why the paper's talking about where savings can be made.
Yes.
So I get the point. I think I would call it, there comes a point, does there not, where salami slicing, for want of a better word.
Absolutely.
It's a waste of time and effort. Been there, got the T-shirt many times. And I think you're saying major transformation has to be looked at to be realistic.
Absolutely.
I always like to be realistic. I don't like to raise people's expectations when I can't deliver. So I suspect you're telling me there are big issues coming down the line and they will impact on the joint projects between the NHS and the Nottinghamshire County Council. Probably.
In some areas, yes.
Fine, thank you. Interested to see what those are.
Absolutely. Councillor Barlow.
Obviously, there could be potential community impact if services are cut. So could you sort of clarify what community-based services that could be cut?
I can't tell you right now. We are looking at more integrated ways of working. So, for example, we will still have district nursing teams and social care teams. But what we're saying is, if you work together, coming together as a single united team, we think that we can extract more opportunity to support more people with the resources that we've got. And therefore, if there is any depletion of any of those resources, we can still provide the right care to that people within a neighbourhood population. So we know that one of our biggest costs is workforce. It is within the NHS. It's one of the biggest areas of spend across all our acute and community providers. So we do know through the workforce programme that we are going to have to cut staff. We are going to have to cut the numbers of staff. But what we're trying to do is do that in a way that it doesn't impact on the frontline care for people in a significant way. What we're trying to do is say we may have fewer district nurses, or we may have fewer of a particular type of person, but actually by building the teams in a much more integrated way, we can cover that and still provide the support that people need at a local level. Because we do know we have occasions where, a district nurse will go out to somebody and they'll do one thing for somebody and say, yes, but I'm not touching that wound, or I'm not doing that stitch, or I'm not taking your blood pressure, or those kind of things. And then somebody else will have to come out and do that, whether it's somebody from the GP practice, for example, that might do it, or another member of the team, of the district community team. So what we're trying to say is actually let one person be able to do more functions and more skills within a range, and support them to do that, so that actually we make the best use of the available resources that we've got. We absolutely do know, as just indicated, we do need to transform our services. We cannot continue the way that we've currently got them organised and achieve that financial balance. So workforce skill mix, changing how we work, are one of those key issues that we're trying to achieve through this transformational set of transformational change programmes.
Councillor Faggiel.
Appendix 1 is a big list of work streams. Go into a little bit more detail about, are these things that you're definitely implementing? Are they all going to happen? Some of them going to happen? chosen? Have they been costed? You know, how many savings have been made by each one? Not loads of information on them. There's like a sentence on some of them. It doesn't, in isolation, mean much. Some of them are a bit more disconcerting than others. And just wondering if you could
This is kind of a general menu of what people are looking at the moment, and some of them will be a twinkle in the milkman's eye, as it were. Some of them are far more developed and thought through. So this is the point really of the early conversation. As these do mature, and as some of these, if you've got a particular, we can come back and talk to you, but it will be those where we feel that there has been, as our statutory responsibility, a significant change, that we will be much more interested in coming and have a conversation. Where there's no change to people in the way that I've described, there's loads of stuff that we're doing in here that frontline care will not be impacted. Our anticipation is that it won't be impacted. And what we will do is be keeping an eye on that as well. So we will be going back and reviewing, has there been an impact? Was it what we thought? Have there been any unintended consequences? That will be part of an evaluation process that we will do. So what we want to do here is spell out and support you in understanding the general menu of the things that we're looking at, but there is a very variable level of maturity of the thinking in them.
So it's a really good question, Councillor Facio, and we struggle sometimes. We could have sent you a paper 50 times longer and you said, oh, I can't make head nor tail of this, too much detail. So we very deliberately sent you a shorter paper, and rightly you're saying, I want to see more detail on these. So, but this isn't the only time we're going to have this conversation, I can guarantee that. So if there are particular topics or particular kind of, themes that you want to understand more on, that's something we could agree, maybe even in the summing up of this or kind of subsequently with the committee's leadership. We'd be really happy to kind of get into it.
Yeah. If you want to deep dive in on one of the programmes, for example, that, you flagged a few, we can come back and talk to you about them.
Should I flag a couple now that just leaked out? So in number 3 is states, like improvements in medical gases and asthma medication. I don't know what that means, but is that something to do with like reducing inhalers, or is that about gas and air in the paper?
It's the CO2. So we're changing the inhalers so that they release less CO2, for example. It's much more sustainable, and actually disposal. So it's that kind of thing.
Right. Okay. And then we're looking at reducing patients taking use medicines and decreasing the prescription items, and how that would be done and how much that would save.
Yeah. So those are the kind of things like, for example, encouraging people to use a community pharmacist dispenser, for example. What we found is that, again, there's a research evidence around this. People very often just get repeat prescriptions because I just get my repeat prescription. The fact that, I've been into my grandma's house and she had like cupboards full of paracetamol that she never ever took, and she used to give them out like sweeties to all the grandkids. So some people, just because it's on repeat, they just accept it. Whereas what we're trying to do is say to people, can you phone if you need it? And not just it. So if those are the kind of things, the opportunities that we're saying will release a lot of money savings without impacting on direct patient care. We're trying to be really careful about making sure every penny goes where it needs to go.
And I'd go even further, actually. It's not just, might be something you don't need that's a waste. Over time, citizens with complex needs, they'll get new medication layered on, and perhaps for many years someone hasn't sat down, a doctor or a nurse or a pharmacist sat down and said, why have you got that and that? They both kind of do the same thing, or worse, that one makes that one less effective. So this is not only, in fact, it's predominantly not about saving money, it's actually about delivering better care. Yeah. And the number of times that the pharmacists look at this and improve people's health by giving them fewer medications, which is completely counterintuitive, isn't it? But it happens time and time again. So that's one of the examples that falls into that medicines optimizations piece.
The last one I want to make is urgent emergency care, manage end-of-life cases and reduce waiting lists. That palliative care, obviously, assisted diet's all been in the news a lot recently. I think that's something that I'd be really interested to know more about, what that means, what that would look like for patients, and cost implications of that as well.
Yeah, no, absolutely. We can touch on a lot more detail. In effect, what we do is we've got a really good data intelligence unit, and that gives us a lot of information about people's use of system, acute care, primary care. And what we found is that actually there are a lot of people who are being admitted into hospital towards the end period of their life who actually are choosing or stating that they want to die at home, they want to die well at home, and yet we're still admitting people. So a lot of the way that we want to change the way that community services work is helping people to stay in their own home, well cared for in that last period of life, and not putting them into expensive hospital-based environment, because that's not what they want, and that's not necessarily good for their overall, end stage. So what we're trying to do is re-engineer how we do things in community, so it's always home first. That speaks to that kind of thing, so that if somebody is at crisis or they're in themselves and the families and or in a care home, we're a bit really concerned, somebody's gone off the legs, they're feeling unwell, normally pick up the phone, ambulance, straight over to a hospital. We don't want that for older people, because actually that's not what they want for themselves in most instances. So we need to support people better, and that means giving them really good support to stay well at home for longer. So that's a whole kind of philosophy of the approach that we're trying to take around the transformation agenda that we've got.
Sabrina?
Yeah, so speaking from a VCSE voluntary sector, it's not something I've seen really represented in your report. And Alex, you talked about letting know if we've heard anything. We have been contacted at Healthwatch by our VCSE colleagues in Bassett Law. And I'll just quickly read through what they've shared with us, which is the fact that the ICB will be considering removing funding from 10 local charities and services in Bassett Law, including the Bassett Law Action Centre, Bassett Law Community Voluntary Services and others. And the key risk that they've identified is that 4,000 of the most vulnerable citizens in Bassett Law who receive direct support from those funded services per year with a further 10,000 people receiving indirect support as a result of this investment. And the removal of this funding from Bassett Law would result in increased pressure and impact on primary and secondary care services, i.e. GPs and hospitals in Bassett Law, and a significant value for money and the added value currently provided through volunteer time and a very experienced and trusted local workforce and charity match funding will also be lost if the core funding for these services is removed. So the 10 charities and VCSE organisations under the review received a 6 months extension going up until October, I think, of this year. And the BCVS have published a paper outlining the risks and their concerns. And the question I guess they had, which they wanted us to share, which is, what will the ICB do to address the serious risks created to Bassett Law patients identified through the review already undertaken?
Yeah. So the decision on that is going through our internal process right now, and those concerns are and will be considered as part of that review and the decision that we'll be doing very shortly. We're very acutely aware of the amazing job that all our voluntary sector organisations do across our patch, and the absolutely important and critical role they play in supporting people to stay healthy and well. And that is not lost on us, and they are a significant partner with us in meeting the needs of local people. We do take that extremely seriously, and it is a partnership as well. And we've reaffirmed that actually recently in the ICB board meeting, where we focused on the role of voluntary sector organisations, and they were very, very open to our commitment that we want to continue to work with them in a very productive way. The particular circumstances around Bassett Law are that they're in a unique position in many ways because of the historic way that Bassett Law came into the rest of Nottinghamshire. And as a result of that, there is funding into Bassett Law that is not available for any other voluntary sector organisation in the rest of the whole patch. And what we are trying to do is to be fair and equitable, and as well as address issues of inequity, which is also important in our consideration of any future funding arrangement. So absolutely hear that, absolutely hear the concerns that people have, and it will be going through our internal process for consideration in terms of what we do next around our funding. I think there's something about as getting onto a front foot of future arrangement and working with the voluntary sector in a much more constructive way, which is where I think we need to be.
Yeah, I guess it's understanding what the plans are for if those services disappear, then what is the narrative and the explanation for those people in those areas to understand what the ICB wish to do to support those residents in that area, because if they don't have a service, they don't know what's happening next, and I think that's the bit that they're concerned about.
Yeah.
What is the actual explanation for them to understand?
If that decision is made, we will go through that with them and we'll support an exit approach.
Thank you, Julie. I've got a question to ask. Basically, it's a bit of a question from Fascio, sorry. Basically, it's about paracetamol and it's got the repeat prescriptions for cost of the NHS itself. And I want to know about paracetamol, and you can get them off the counter as is that included as well? Has that been taken off itself? Because if we just go to the store, spend money about 10p for a pack of paracetamol itself.
Yeah, we do. We already very much encourage that. So I was just giving that as an example of what has happened. But yes, we already do encourage people to purchase medication where it's over the counter and it's relatively cheap and easy to do that. But that can't be for the case for everybody, because as you know, some people really struggle and will struggle with that. So in exceptional circumstances, although we do for the majority of people suggest over the counter medication, that isn't universal.
Any other members wish to? Yeah. No? Okay. For me, I do thank you for the report and obviously running us through the slides at the start, plus your ad lib as well. That was very much appreciated. One thing for me, this is a 2025-2026 transformation plan with a forecast of savings. I work for an American company, so we work on calendar years rather than financial. Are we talking financial? Financial year. Okay.
March next year.
Yes. So we're already through Q1 of that. For me, and I think a number of the committee members highlighted this, what we see after Q1 of that year is just a very high level report with very little detail. So what I would like to see, and I'm sure I'm putting words in the mouths of the committee here, but I'm sure what other committee members would like to see is more fleshed out proposals that we can look at and scrutinise to understand what the impacts are going to be and whether we can foresee any future issues, unintended consequences, impact to residents and things like that. So would it be a possibility to get a more detailed report breaking down your 8 work streams so that we can see, you know, more about what the actual nuts and bolts are and where you're going to get those savings in each work stream?
The profiling of the savings is very much towards Q3, Q4, as you can imagine. So, and that's why some of these are still very much not at a level of maturity that we can give you definitively what the impact, but we can bring you a little bit more detail within them. We've tried to do that in what we've given you so far, but yeah, we can put a little bit more flesh on that.
Be really keen to work with you, probably kind of, you know, offline ahead of the appropriate committee slots so that we get this right, because as we kind of discussed earlier, we could swing to too much, to too little. We want to hit it in that sweet spot. So let's talk about what would really work for you in the committee.
Sounds good to me. So if there's no further discussion, I'll proceed to recommendations. So the recommendations be that the feedback of members on the approach to proposed sustainability measures be noted. Can I have a seconder for that proposal? Councillor Adagoki. And all in favour? And a second recommendation that a detailed report regarding the proposed measures, associated impacts on residents and proposed mitigations be received. I have a seconder first, sorry. Second, Councillor Barlow to second. All in favour? There we go. Right, so we will move on to our final item, which is work programme. So a few matters to highlight in respect to the work programme. The work programme event will be scheduled, or a work programme event will be scheduled before the next committee meeting to give members the opportunity to determine our health scrutiny priorities and compile the work programme for the coming year. The dates in the appendix are only indicative and will be confirmed in due course. I'd like to just open up discussion to see what committee members' thoughts are about items for future work programme. Councillor Wheeler.
Thank you. I think just a big confusion because the second recommendation is that the priority be delegated to yourself, to Catherine, to the Vice Chairman to work on the work programme, but we're then going to have the workshop. So to me, it makes more sense to go to the workshop first on that sense and to look at the work programme, because especially from new members of the committee, because there are obviously the various different organisations like Health Wellbeing Board, there's internal health scrutiny might be different. You know, people might want to raise an item, might be better to recommend their way. I think personally, should we have that workshop first to go through it, flesh it out to the issues. It also gives members here a chance to go back to our respective groups, chat to our councillors, especially new members to position their own divisions, especially so we can come to that workshop and review it. And also it's more information. For example, we've had the Cavill Centre on there for years because the previous councillor always put it on there, and I'm sure it was not done for the election at all, but just before the election period, it was announced in Nashville that they are going to buy the sixth form college and give it to you. So I'm sure you're very much looking forward to that for the new health centre, but not seeing anything more since, I believe. So I think just in terms of understanding if that's happening first, if it is, great, save us some money saved. I'm sure that originally, but if it's not, then of course we'll have to look at that item because it was just kept a rolling item there, and I think it's just to understand that information first. Of course, we work with 2 health centres. It does that's actually there to find out that's happening, and like I say, it just gives more time for committee members to go up to their own particular areas, their residents, and to fellow councillors to pull information together.
Absolutely.
Can I respond to this one, Chair?
Yeah, absolutely. Yeah.
Thank you. Okay, so I completely take your point, and I really like the idea that you are enthusiastic, Councillor Wheeler, about getting everybody around the table and building our work programme. That's what we really want to do. And you'll see in our tentative schedule that our work programming event is before our next meeting, which you know, we aim for it to be. But the reason that that recommendation is there is so that we can start the work to prepare for that September meeting now, which, as you know, we have a recess in August. So actually the lead time on these agenda items is actually quite long. We work with our partners very closely to refine the scope for each item for those reports that come. So so they are quite a while in train before the 23rd of September. So that's the reason why I need the authority to make those arrangements on the behalf of members of this committee.
I get it completely. So I was trying to understand if the workshop's planned for say 2 weeks' time, that would be different. But so if you're not planning that workshop until September, obviously that obviously gives that context either to it. So I understand that. I think it was just more to understand those timescales where you look at these workshops, so that made more sense.
Yeah.
Right. And Chair, we absolutely, you know, we totally affirm the rights of the committee to make changes to the work program at any point. So even if something does go on the work program, that's not set in stone. That is something that is indicative. So it can all change at the work programming event. So even if we did go in and go, okay, here's how we think the year should go, the priorities will that this committee sets will be reflected in how those items are scheduled in the year. So I just wanted to provide some assurance to you, Councillor Wheeler, that we are going to be listening to yourselves and guided by yourselves as to how that work program goes. Thank you, Chair.
Councillor Barlow?
Yes, okay, it's John for question.
All right, okay, lovely. Have any other members wish to bring forth? No? I'll keep that short and sweet then. So proceed to recommendations. So the recommendation that the work programme and scrutiny criteria be noted. We have a seconder. Councillor Rich, and all in favour? Carried. And Recommendation 2, that the authority be delegated to the Health Scrutiny Lead to update the work programme as appropriate in consultation with the Chair, Vice Chair and representatives of the relevant partner organisations, with any changes reported to the next meeting. Have a second one. Councillor Cox, all in favour? There we go. So all that remains is to thank the ICB and Healthwatch partners, officers and members for attending this meeting and contributing to the discussions today. With that, I now formally close the meeting and ask to please conclude the broadcast.